Hey everyone, for those of you who are here, thank you for being here on time and attending conference today. I am recording this and we'll put it on YouTube later for those who aren't able to join. And I also sent out an email just now reminding people to join noon conference every day, unless they have urgent patient issues ongoing. But we will be using a lot of polling today for conference, and here is how you can join. So I'll let you guys take a minute to join on the computer. It's easier if you're on a web browser to do this. And then we'll have another reminder on how to join here in a few slides. So we're going to be talking about hyponatremia today. I know that Mira during base camp did a lecture on this, and so subsequent conferences on this will add on it. And today we're going to do some advanced management. And so given that, the objectives for today are to manage hyponatremia in various scenarios, anticipating overcorrection and acting accordingly, and then finally defining the utility of urine studies for hyponatremia. Before we get started, as always for my conferences, I like doing echo primers, and so this will be likely our last one, but if you guys could identify the right ventricle in this image by clicking on the area where you think it is. All right, so correct, the people that answered are identifying the correct area. And so the right ventricle in this parasternal short axis view is correctly that chamber. And so just to show you guys what the rest of this image is showing. So that's the right ventricle. Here's the left ventricle. Here's the interventricular septum, which we've essentially seen in each view that we've looked at for the echoes. And then here we have the papillary muscles, which look like boxing gloves. And then again, just a reminder that the probe marker should be on the right side of the ultrasound screen when you're doing a cardiac ultrasound or echo. And so these images have the probe markers on the right. And then just remember the parasternal long axis view is not just one view, but it's multiple views. And so you can pan your probe up and down, so sort of superiorly and inferiorly to catch different sections of this view. And so most inferiorly, you'll see the apex of the left ventricle, and helpful to see apical contraction and making sure the apex isn't hypokinetic. And then as you pan superiorly, you'll catch this view, which is the papillary muscle view. Further superiorly, you will see the mitral valve, which looks like a fish mouth. And then even more superiorly to that, you'll catch a view where you'll see the Mercedes sign of the trileaflet or normal trileaflet aortic valve with more of the atrial chambers. And so this, I chose today the papillary muscle view, parasternal short axis. Great. So just a reminder for those that have joined the conference is we have poll EV questions coming up. And so please join so that we can all participate. Okay, so we're talking about hyponatremia today. And just to define it for you, technically it's any level of sodium less than 135. but hyponatremia is considered pretty severe if it's less than 120. And then remember that it's really bad if it's less than 105. And the data shows that there's a greatest risk of osmotic demyelination syndrome if overcorrected when you start with levels less than 105. And so this is sort of how I prioritize it in my mind. And then just remember that there's acute and chronic hyponatremia, and that chronic just means that it's existing for more than 48 hours. So essentially most patients that we treat will be considered to have chronic hyponatremia. So having said that, here's our first case. So a 24-year-old female is evaluated in the emergency department for confusion. She was brought in by friends at 3 a.m. after they went clubbing. She's otherwise healthy. These are her vital signs. So I'll let you guys take a look for a second. And then here is her BMP. So here are vitals again. And then with that context, here's her BMP. And so as you can see, she has hyponatremia to 118. The rest of her labs don't look so bad. And so how do you want to treat her hyponatremia? Okay, great. So I encourage people who are on to join Poll EV. There are a few more questions coming up, but the correct answer to this question is actually 3% saline, 100 milliliter bolus. And let's talk about why. So the key points here are that this patient has acute hyponatremia. She was acting normally, was fine until she went clubbing, and then she was acutely confused. And so in this patient who, yes, correct, Sarah, and want to restrict. Yeah, so that's a fair point. So the reason the answer for this patient is, sorry, my computer's acting up. The reason the answer is 3% saline for this patient is because she has neurologic changes with hyponatremia. And so if you have confusion, seizures, or coma with hyponatremia, you have to treat that acutely and want at least a 2 to 3 point rise in your sodium. And the quickest way for us to achieve that with the smallest amount of fluid is to give 3% saline. And so Sarah, your chat is absolutely right. So in her, we're suspecting that she likely took ecstasy or MDMA, which can often cause hyponatremia by mechanism of SIADH. These patients also often have polydipsia. And so that combination causes hyponatremia. And so to treat her confusion, we're going to use 3% saline. The other medications that can cause acute hyponatremia are mood agents, antipsychotics, and then I didn't list it here, but anti-epileptics as well. There's also an entity called exercise-associated hyponatremia. It's quite common in marathon runners, typically running more than 4 miles. But of course, marathons are much longer than that. And then it's worsened essentially by drinking a lot of water. And so acute polydipsia in the setting of aggressive exercise. And then quite often post-surgically, where patients get a lot of fluids all at once. Post-surgically, pain and nausea can also cause ADH release, and so essentially an SIADH picture. And so all of these things we treat if the patient has neurologic changes with 3% saline. It's also called hypertonic saline. You do 100 milliliter bolus, so it's a small amount, and you're looking for a rise in the serum sodium of 2 to 3 points. And if that first rise, the patient's symptoms aren't abated, that you can repeat this bolus 1 to 3 times. Again, just to emphasize, if you have acute hyponatremia or very severe chronic hyponatremia, but have these neurologic findings, you have to correct that sodium rapidly, at least in the short term, to abate those symptoms. And then anytime I'm considering using hypertonic saline, I either get my attending involved or just call renal because misdosing hypertonic saline can result in death. And so regardless of training level, I'd encourage you to just get a second set of eyes on your order, whether it be your senior or your attending or renal. And even at my level, I prefer calling renal just to make sure that I'm dosing this correctly. Okay, so that's acute hyponatremia. We don't see it very often. Most commonly, we see chronic hyponatremia. So let's get into that. So now we're seeing a 63-year-old man who's evaluated for dizziness. The dizziness symptoms have been ongoing for a month, but he had some pre-syncope and a fall today, which is why he came in. These are his vital signs. He's tachycardic. He's got low blood pressures. He's thin. And this is his BNP. He has hyponatremia, hypokalemia, and what looks to be a renal injury. His baseline creatinine is 0.7. And so let's see what we'll do for him. So for this patient, given that limited amount of information, what pertinent history question should we ask? Older patient, dizziness, hyponatremia, thin. PO intake, yep, that's good. The ED will tell you in a little bit what's going on with his PO intake. Zachary says, are you taking hydrochlorothiazide? Yep, so you want to ask about medications? Absolutely. Med list, yep. So he doesn't take any medications at home. His PO intake consists mostly of alcohol. He has alcohol use disorder and doesn't really eat or drink much aside from that. Vomiting or diarrhea. Yeah, he has had some diarrhea of late. He has a history of chronic pancreatitis and isn't really great about taking his Creon. He hasn't had a ton of vomiting. Anything else? So good. I think most of you guys focused here, at least the people that are participating, on getting a history regarding the patient's fluid status. And then just remember that history also contains social history, which is quite important in these cases. And so you're going to ask about whether they've had any fluid losses, what their PO intake has been like, what their medications are. So sometimes diuretics can cause hyponatremia. And then social history-wise, in a patient who, say, is a BMI of 21 as a 63-year-old, may not be super normal. And so asking about alcohol use, asking about smoking, because remember, smoking can cause lung cancer, which can cause SIADH, which can cause low sodium. And so making sure that you're asking some of those age-appropriate cancer screening type things. Recent surgery or trauma, yeah, absolutely. So any head injury, yep. So any trauma history, all of those are great things to ask, especially in this patient who's having dizziness and then just fell. So did he have head injury? Would be helpful to know. head injury and SIADH in the setting of his vital signs, and the sodium of 118 would be unusual, but absolutely you should ask about that. So good work. Okay, so then what key exam findings will you look for in this patient who was afebrile, was tachycardic, pressures in the 100s, and citing okay? Yeah. Mm-hmm. Yeah, right. You guys hit the nail on the head there. Don't need to go much into this, but remember that our hyponatremia evaluation hinges upon the volume status exam, and that is where we must begin. And remember that today I'm not going to trick you by giving you a case um, of pseudohyponatremia, which is hyperosmolar, right? Which is can be caused by things like having an elevated triglyceride level or elevated sugar level. And then I'm also not going to give you things that like hypothyroidism can cause hyponatremia. Today we're talking about hypotonic hyponatremia, which is what exists in most patients. And for hypotonic hyponatremia, we start with our volume exam. And so look at their mucous membranes, look for JVD, look for signs of edema, look for ascites, and then these things can help you identify whether the patient's overloaded or dehydrated. Just an aside, which I haven't included here, but was reminded of, is that axillary sweating is one of the most highest odds ratios for dehydration. And so I ask that to patients, but people aren't really aware of how much they're sweating, but just an interesting tidbit for y'all. Okay, so then one last thing is when you start to admit patients like this more and more, whether you're alone or doing it with your senior resident, what are, I asked what one question should you ask the ED, but there are a couple questions that you can ask, but what's the most important for us to know before we can start taking care of this patient? Yeah, great. How many liters, plural, you're just going for it? Yeah, fabulous. So this is the correct answer is how much fluid the patient has received, so that you can figure out where this care is going. And the only other thing for this patient that would be important is IV access is pretty important when you're going to be taking care of patients with severe hyponatremia. So sometimes I like to ask what IV access they have. And then lastly, for this patient, disposition matters, right? And so you're going to have to decide where you're going to put them on the floor or the ICU and step down at some places. Okay, cool. So here's the ED resident sign out for you. So they tell you that the patient has a history of alcohol use disorder, chronic pancreatitis. He is complaining of diarrhea, doesn't take any meds at home. The exam is consistent with dehydration, so hypovolemia. And then the ED so far has given a liter of normal saline, and they started him on SOS and gave him some good thiamine folate stuff. Cool. I talked about disposition a little bit, but I'd like for you guys to think where this patient should go. And then what other initial orders will you be placing for this patient? Okay. Good, so let me address these as they sort of come in. So I agree with ICU. There's one answer for Q2 BMP and one answer for Q4 BMP. So this is of course stylistic, but most people say that you should do Q4 BMPs. More frequently, of course, is desirable. But what often happens with these patients is they go up to the ICU, they get whatever fluids you ordered, then you have to let that fluid equilibrate for their body to adjust to it. And then the next check is up, the nurse has to drive, the sample has to go to lab, it has to be run, then you get called. And if you try to do it Q2, there's really not enough time for all of those events to happen before the next check comes. And so you won't be able to make educated treatment plans. And so Q4 just gives you more time for the body to equilibrate and for the nurses to be able to do their job. For us to get an idea of what's happening with the patient's sodiums. So typically we do Q4. And then the answer that said NA under 120 usually make you correct for monitoring and in case they need rapid correction. So just remember, in case they need rapid correction would only be in the case if they were having neurologic symptoms like encephalopathy, seizure, or coma, which this patient isn't having. So we aren't going to very rapidly correct them. And then see if sodium improves with fluids, if not, fluid restrict. Yep, okay. So we're trying to figure out if this is purely hypovolemic hyponatremia or if there are other components at play. Great, a couple other things just to think about are considering a chest x-ray, which is a low-cost, non-invasive test just to make sure that this patient doesn't have like a big old mass or something. And the question of, head CT always comes up. And so because this patient isn't confused, seems to be maintaining okay, you don't necessarily have to get a head CT unless you think they may have had a bleed from their fall, but the patient didn't have any signs of trauma. And then sometimes it is helpful to place a Foley for these patients. Especially if you're concerned with overcorrection. So that is something you should consider or just think about. And then remember I mentioned IV access earlier, so it's very helpful for these patients to have 2 IVs in place, and we'll talk a little bit about why that is the case. But good job. So this patient's going to the ICU, and we're gonna do some frequent labs. You can choose the number, but I do Q4. Okay, so what will be our correction rate for the first 24 hours for this patient? Great, we have some controversy here. And so I will get on my soapbox, but if at any point you guys have studies I don't know about or clinical reasoning that you think I'm missing, please always chat it or speak up. I'm learning alongside you. I may just have like 6 months more experience, but the correct answer here could be 4 to 6 or 6 to 8. So most typically we've been aiming for 6 to 8. So the majority here is correct. But given this patient's malnutrition, his BMI is 21, given his history of alcohol use disorder, both of which conditions cause you to have a higher risk of osmotic demyelination syndrome, 4 to 6 would not be incorrect. So essentially aim for 6, which is a really safe number to aim for this patient in the first 24 hours. And then the third big risk factor for ODS is starting at a low sodium level. So remember earlier I mentioned that if you start at a level less than 105, that's really bad. With this patient being closer to 120, he's at 118, theoretically the risk is lower, but again, his alcohol use and his malnutrition put him at higher risk. So for him, we're gonna do more gentle correction. So if you aim for a level of 6, it's going to be pretty safe. But again, A is not incorrect, and you wouldn't be harming him. His length of stay may increase, but 6 to 8 is normally where we aim for. Both C and D have fallen out of favor now, and that would be too much correction. So you would be overcorrecting with those values, and that would put this patient at higher risk for ODS. And so remember, just try to make it less than 8. And then just to reiterate, if a patient is having neurologic changes, you may have to, at least in the first few hours, correct more rapidly. So talk with somebody, talk with renal in that case, and come up with a number that you're gonna aim for to monitor those symptoms going away. Okay, and then one more question for you guys. It's true or false? I anticipate this patient will overcorrect. Yeah, yep, I agree. So I think this patient will overcorrect. The smart answer would be to say, hey, if I do my job right, we'll prevent that. But because the ED has given him a liter of normal saline already, and sometimes they give more fluid than that, there's a high chance that in the short term, this patient is going to overcorrect, meaning go past the 6 to 8 number that we've set for the first 24 hours. Then we're going to have to help him along to bring that sodium back down into a range that we want. And so let's talk about how we're going to do that and what overcorrection really means. So why does overcorrection occur? I think understanding the pathophysiology here a little bit is really helpful and has helped me understand hyponatremia better. And so remember, in this patient, now we know that he has hypovolemic hyponatremia, meaning he has decreased atrial receptors, he has some sympathetic stimulation going on, his angiotensin system is jacked up, trying to get his blood pressure up. And so all of these things cause for pituitary to release ADH, which is also called vasopressin, which results in both blood vessel constriction and free water reabsorption in the kidney level, all of which works to increase your arterial pressure. And so in this patient who's fluid down, ADH is causing free water resorption to get the plasma volume to rise by trying to rise, and so to try to raise the blood pressure. So how does overcorrection work? So what happens is you give this patient an NS bolus or more fluid to try and get their vital signs to look better. And you actually should do it. If a patient is septic, if they're hypotensive, they need the bolus. So you're just gonna give the bolus. So that's fine. The ED did the right thing to try to treat his vital signs. So they give him a bolus, which causes this entire system to shut off. Meaning ADH turns off because your hypothalamus is like, great, we got the plasma volume that we wanted. We're gonna shut the whole thing down. So ADH turns off. And as soon as ADH turns off, there's rapid free water excretion. So all that free water that your body was trying to retain with ADH now is in your urine. And so you're losing free water, and that causes the serum sodium to rise. And so because we gave this patient some volume, ADH shut off, and then free water excretion occurred, which causes the serum sodium to rise. And if the serum sodium rises above that 6 to 8 mark over the first 24 hours, that's called overcorrection. And so we're gonna have to work to bring that serum sodium back down. So let's see how we do that. So what should you do? So you have 3 options. Option 1, like I was mentioning earlier, is you could consider placing a Foley. And then once the patient's vitals have stabilized, you just watch the Foley. You ask the nurse to do Q1 hour outputs. And then you can start matching their urine output with D5W. And what happens is, like I said, so your free water excretion. So now whatever urine you're making is basically free water. So the idea here is that if I'm peeing 200 cc's an hour, that's how much free water I'm losing. And so to keep the sodium at a level where it's now, let's say from 118 to 121, to keep it there, I need to give myself that amount of free water back. And so the way we do that in the hospital is by using D5W. If the patient can take PO intake, they can also try to match it with PO intake, but it's quite hard to take like liters and liters of fluids. So you're gonna have to help them with D5W. And here's where having multiple accesses comes in handy, because I've taken care of patients that come in with hyponatremia and pancreatitis. I've taken care of patients that come in with hyponatremia and DKA. And in all of these conditions, you may be simultaneously running normal saline or LR and at the same time D5W. So you gotta have two IVs for these patients so that you can run multiple fluids at once. So that's first option. Second option is similar. So you can calculate a free water deficit. And I did that for you for this patient. So basically what you do is you go to your calculator, you put in the sodium they're at. So let's say with that 1 liter normal saline, he jumped from 118 to 130, which is way too high. And we want to bring him back down to 122. The calculator will tell you that this person has 2.1 liter free water deficit. Let's round down to 2,000 milliliters. And then you can run that as 200 cc's per hour. And so you can calculate your free water deficit and you can give that back as D5W at 100 to 200 cc's per hour rate. Please do not bolus D5W. That can cause a lot of large fluid shifts in the brain and can cause cerebral edema. So D5W you should always run at a low rate and not bolus. So that's your second option. And then the third option is to give DDAVP, which is essentially ADH, because remember ADH is shut off in our body, so you can give the patient ADH to cause free water retention and clamp the sodium at a level that you want. So say 122. They're at 122, you give DDAVP, the patient won't pee up any more free water and they'll stay at 122 until the DDAVP wears off and then they'll start to go up. There is some recent literature that suggests that early DDAVP in these severe hyponatremias is helpful, and it's called the clamp method. I think clinical use of this method is still low. And if you're considering it, just talk with renal. I think they like to know when you're going to use DDAVP and they can help you dose it. But most commonly we use option number 2 followed by option number 1 and then DDAVP when D5W just isn't cutting it and the patient continues to overcorrect. So I know these can be complicated conversations, so please feel free to chat questions if they come up. Okay. So one last thing I wanted to talk about today is what about urine studies? We always hear about them, we're encouraged to get them, renal wants them. So let's just talk a little bit about how urine studies can be helpful with hyponatremia. And I'm going to try to simplify it for you guys because I know it can be confusing, but we're going to go through some practical examples and see if we can't simplify it. So ideally, these should be obtained prior to any intervention. It's pretty rare that the emergency department will get them for you, but if they'd gotten them before the liter of saline went in, that would be the best case scenario. But really, better late than never, honestly. So you could get it before you consider giving any more fluids, and it can be useful for trending. So I try to get them earlier, and then you'll need them if you're going to be calling a renal consult because our nephrologists like knowing the urine studies, and so you should get those. And when I say urine studies, I mean urine osms and urine sodium. And then this concept is going to come up here in a second again. So just remember, ADH is a hormone that causes free water back into the body. It causes free water retention. Okay, so we're going to simplify. So first, let's talk about urine osms. You really only need to look at it if the patient is in a hypovolemic or euvolemic state, or you're confused between the two, because a lot of patients come in, they're kind of dry, but they could be euvolemic, and you just don't know what's going on with their volume status. It's a measure of free water excretion, and it's controlled by ADH and ADH alone. So for example, you can be in one of these two states. You can either have a low effective circulating volume or high extracellular fluid osms. These are the two things that control ADH in our brain. Or you can be in a state like primary polydipsia, where you're drinking a ton of water, or you're malnourished and therefore your extracellular fluid osms are low because you have no solute intake. So these are the two buckets. Either you have low effective volume or you have normal or high effective volume. So let's see what happens. When you have low circulating volume, ADH turns on. It causes free water retention, because remember, you're trying to increase this plasma volume. And therefore, you'll have concentrated urine because all the free water is going back into the body. And so therefore, your osms will be more than 100. In primary polydipsia, where you have tons of free water incoming, your body's like, that's too much free water. I got to get rid of it. So it's going to pee that water out. Your ADH is shut off. And so you're going to have a dilute urine. Your osms are going to be less than 100. For malnutrition, similarly, because you have no solute intake, your extracellular fluid osmolality is low, and so your body's like, man, I gotta get this osms high, so I'm gonna get rid of water so that I can concentrate the solute in my body. And so this is the reason in these two conditions, your urine osm is going to be less than 100, meaning you have dilute urine. Similarly, if we think about urine sodium is a measure of blood pressure as seen by the kidneys and is controlled by the kidneys alone. So for example, there are two states. Either your kidneys aren't happy because there's low effective BP, or they're fine because the BP is fine. So when your BP is low or perceived to be low by the kidneys, it's going to try to retain salt. It's gonna wanna retain sodium because it wants water to follow salt to increase your blood pressure. Similarly, if the kidneys are happy, they don't really care. They're like, fine, I'm good. Sodium can go out of the body the way it comes in. It's going to be unregulated. And so essentially it can be any number. It just won't be low. And so remember, the reason it's low here in any state where the kidneys are perceiving a low blood pressure is because it wants salt and water back into the body to increase your blood pressure. So urine osms are controlled by ADH. Urine sodium is controlled just by your kidneys. And so if we put this together, we can take SIADH as an example. So in SIADH, what's happening with your plasma volume? Okay, SIADH is inappropriate ADH, so that doesn't care about your plasma volume. And so what's going to happen is you're going to be retaining all that free water, because remember, ADH causes free water back into the body. And so you're going to have a concentrated urine osm, which is greater than 100. And then what's going on with blood pressure in a patient with SIADH? They have euvolemia. They normally have good pressures. And so the kidney is going to be dumping sodium normally in an unregulated manner. And so the urine sodium is essentially not low in SIADH. And so put this all together for you guys. I really like this table, and feel free to take a picture of it for your reference. But if we go down this hypotonic hyponatremia path, first thing you look at urine osms. And if the urine osms are high, meaning your urine is concentrated, your body, it has ADH turned on, and it's trying to retain plasma volume. And then the next step to look at is urine sodium. And if urine sodium is low, it means your kidneys are also seeing low blood pressure. And we know that that happens in states of hypovolemia, in CHF and cirrhosis, where there is a perceived low pressure by poor forward flow. And so your kidneys trying to retain sodium, and so sodium will be low. In all these other conditions where your kidneys are fine, they are not going to regulate sodium, and therefore the sodium is high. And so that's how I like to think about ADH and sodium and what your urine studies look like. So just to summarize, we talked about managing hyponatremia, acute versus chronic. Remember to treat early if there are neurologic changes. Anticipate overcorrection, and our nephrology colleagues are really helpful. They'll call you multiple times to help you manage these patients, and so call them early if you need help. And then just remember that urine studies are helpful if done early, and I still have to look up, but the more you do this and the more you treat hyponatremia, it does get better and easier to treat. And so I would love some feedback for you guys. It's a short 4-question survey to see how we can improve these conferences. But otherwise, thank you for attending, and I'm around if you have any questions.